Welcome to Deep Dive Ortho. Today we're tackling something that, well, frankly, can be a real diagnostic headache for clinicians at all levels. Groin pain. It's not just one thing, is it? It really sits right at that messy intersection, musculoskeletal, visceral, sometimes neurological. It's complex.
It absolutely is. And I think the most crucial point, especially for the experienced professionals listening, is to constantly remind ourselves that groin pain is just geography. It tells us where the pain is, not what it is.
Right.
And the real challenge, I think, is moving beyond that initial, sometimes easy, diagnosis of a muscle strain, which, while common, can mask something else entirely. We need a systematic way to sift through everything, including those less obvious, potentially non-musculoskeletal causes.
Exactly. A premature label can lead down a long, frustrating path for the patient.
Precisely. Ineffective treatment, prolonged recovery.
So that systematic rigor is really our focus today. We want to explore the whole spectrum, from simple strains to, well, this idea of a groin pain syndrome.
Where multiple things might be going on at once.
And we'll lean on frameworks like the Doha Agreement classification to try and bring some structure to it all, essentially creating a kind of clinical roadmap.
A roadmap is a good way to put it. Guiding diagnosis, effective treatment, and, importantly, tailored rehabilitation. For athletes, yes, but also thinking about post-surgical patients, too.
Okay, sounds like a plan. Let's dive in. Right, where do we start? Logically, I suppose, with the most common things clinicians encounter first, the musculoskeletal side?
Yes, let's start there. It makes sense, as you say, it's the highest volume, especially in younger, active people.
So top of the list.
Muscle strain. Almost always, we're talking about the adductor group, specifically the adductor longus, right up near where it attaches to the pubic bone.
Okay.
Usually it's a partial tear, grade 1 or 2. Typically happens with, well, sudden forceful movements. Think of a footballer kicking powerfully, a rugby player changing direction sharply, or even pushing off hard laterally in sports like basketball. That eccentric load.
And the symptoms are pretty classic.
Generally, yes. Patients describe pain, often quite sharp initially, high up on the inner thigh. They might find it difficult to squeeze their legs together, lift the affected leg.
Yeah.
Sometimes they report hearing or feeling a pop, and you might see bruising or swelling develop later. But here's the bit that often gets missed, or perhaps underestimated.
That chronicity.
Exactly, the potential for it to become chronic. An acute mild strain might settle in, say, 4 to 6 weeks with the right management.
Right.
But if it develops into a long-standing adductor tendinopathy where you've got chronic degeneration, maybe some failed healing response in the tendon, well, that's a different beast altogether.
So not just inflammation anymore.
No, we're talking structural changes in the tendon itself.
Okay.
And the rehab timeline for that,
Yeah.
you could easily be looking at 6 months, sometimes significantly longer.
Oh.
It needs really careful load management and targeted exercise.
6 months. That really flags up the importance of getting the diagnosis right early on, doesn't it?
It really does. Because labeling a chronic tendinopathy as just a persistent strain leads to the wrong kind of treatment.
Which brings us neatly to another common label, often used almost interchangeably, but quite different, the sports hernia, or athletic pubalgia. How do we reliably tease that, apart from a high adductor issue?
That's a key differential. The main difference really lies in the location and, crucially, the provocation of the pain.
Right.
A sports hernia isn't a hernia in the classic sense. There's no actual hole with bowel poking through.
Okay.
It's more of a soft tissue injury or weakness in the posterior inguinal wall, maybe involving the attachments of the oblique muscles, the conjoint tendon, sometimes even where the adductors attach nearby. The defining feature is the pain pattern.
Which is?
It's typically more diffuse, felt across the lower abdomen and into the inguinal region. And the absolute key is that it's severely reliably brought on by intense physical activity, sprinting, aggressive core exercises, heavy lifting, those sorts of things.
Right.
And just as reliably, it gets better with complete rest. That history is paramount.
So on examination, no bulge.
Usually not. What you might find is tenderness when you palpate over the conjoint tendon, or perhaps near the deep inguinal ring. And crucially, pain when the patient resists an abdominal contraction like a sit-up or performs a Valsalva maneuver straining against a closed airway. But again, without a palpable mass. It's a functional deficiency, a strain of that layer.
Got it. Okay, moving away from the muscles and fascia. What about the hip joint itself? Sometimes groin pain originates right from the joint.
Absolutely. And we have to consider hip osteoarthritis, OA. Now, most people think of OA as something affecting older adults, which is true,
Yeah.
generally,
Mm-hmm.
but it can definitely present as deep groin pain, sometimes quite insidiously, in younger individuals too, especially if they have underlying risk factors.
Like previous injury?
Exactly. Or perhaps subtle hip dysplasia that they never knew about, obesity, things like that.
Mm-hmm.
The pathology is a progressive wear and tear of the articular cartilage. You get thinning cartilage, increased friction, the bone underneath reacts, maybe forms osteophytes, bony spurs.
Yeah, and the symptoms, how do they differ from a muscle strain?
Stiffness, that's often the giveaway. Unlike a strain, OA pain tends to be worse after periods of inactivity. That classic gelling phenomenon, especially first thing in the morning.
Right, the startup pain.
Precisely. And patients often report a limited range of motion, particularly finding it hard to rotate the hip inwards or flex it fully. Sometimes there's clicking or popping within the joint too.
Okay. And sticking with the joint, but more of a mechanical issue, particularly relevant in athletes, is femorostabular impingement, FAI.
Yes, FAI is incredibly important in this discussion. Often it's the underlying structural issue that kicks off a whole cascade of problems leading to chronic groin pain.
So what exactly is it? A mismatch in the joint shape?
Essentially, yes. It's a bony abutment problem within the hip joint. You have two main types, though often they coexist. There's the cam deformity, which is an extra bump of bone on the ball part of the joint, the femoral head-neck junction.
Right.
And then there's the pincer deformity, where the socket of the acetabulum is too deep or covers too much of the ball.
So either the ball isn't perfectly round, or the socket is too deep, or both.
Correct. And the result is that when the hip moves into certain positions, particularly combinations of high flexion, adduction, moving inwards, and internal rotation.
The Fadiar position.
Exactly, the Fadiar position. Those bony abnormalities make premature contact. They pinch or impinge. And what gets caught in the middle? The labrum, the cartilage rim around the socket, and the adjacent articular cartilage itself.
Leading to damage over time.
Precisely. Patients typically describe the pain as deep, often felt right in the front of the groin, high up.
And how do we confirm FAI? Is it just the Fadiar test on examination?
The Fadiar test is highly suggestive if it reproduces their specific pain. But the real confirmation, and crucially the quantification, comes from imaging. Good quality x-rays are the starting point, looking at the overall shape. But MRI is often needed for more detail on the cartilage and labrum, and particularly for measuring the extent of the bony deformity. We look at specific metrics.
Like the alpha angle.
Yes, the alpha angle is key for cam lesions. It measures how spherical or non-spherical the femoral head-neck junction is. Generally, an angle greater than about 55 degrees is considered abnormal and suggests a significant cam bump that's likely causing impingement.
And you mentioned head-neck offset, too.
Right. The femoral head-neck offset looks at the transition zone. If that step-off distance between the head and neck is reduced typically less than 10 millimeters, it indicates a flatter, less concave junction, again, consistent with cam morphology that can impinge.
And these numbers aren't just academic.
Not at all. They're crucial. They give us objective evidence of a mechanical problem and help guide whether someone might benefit from surgery, like an arthroscopic osteoplasty to reshape the bone, versus sticking with non-operative management.
That makes sense. It provides a structural rationale. Okay, we've covered the main musculoskeletal players, adductors, sports hernia, OA, FAI. But you mentioned earlier we absolutely have to consider the non-musculoskeletal mimics.
We absolutely must. This is where a thorough history and systemic review becomes critical. Missing these can have serious consequences.
So pivoting now to those visceral red flags and perhaps some urological or gynecological issues.
Exactly.
Yeah.
Where else could this pain be coming from? Question. Let's start with the urinary tract. Kidney stones, causing renal colic.
Known for severe pain.
Infamously so. Patients often describe it as the worst pain imaginable. It typically starts quite suddenly in the flank or loin area, but, and this is the key part for groin pain, as the stone moves down the ureter, the pain radiates.
Following the nerve pathways.
Precisely. It follows the distribution of nerves like the genitofemoral and ilioinguinal. So the pain tracks downwards into the lower abdomen, deep into the groin, and can even radiate into the labia in women or the scrotum in men. The pain is typically colicky, coming in intense waves, sharp, cramping. And very often, there are associated symptoms like blood in the urine, hematuria, nausea, or vomiting.
Okay, so very different character to typical MSK pain. What about surgical emergencies?
Appendicitis has to be on the list, especially for right-sided lower abdominal or groin pain. The classic story is crucial here. The pain often starts vaguely around the belly button. Then, usually over hours, it migrates and localizes to the right lower quadrant, McBurney's point, which can be quite close to the groin.
Right.
This becomes a sharp, severe, constant pain, usually associated with loss of appetite, fever, maybe nausea and vomiting. It's the time-critical diagnosis.
Definitely one not to miss. And then particularly thinking about female patients.
Yes, pelvic and gynecological causes are essential differentials. Ovarian cysts, for instance.
Right.
While often silent, if a cyst twists, torsion, or ruptures, it can cause sudden, severe, one-sided lower abdominal or pelvic pain that can easily mimic appendicitis or even renal colic. Needs urgent gynae assessment. And then in pregnancy, there are a couple of common groin pain mimics. Round ligament pain is one.
I've heard of that. Sharp stabbing pain.
Exactly. Often quite fleeting, felt in lower abdomen or groin, typically triggered by sudden movements like rolling over in bed, standing up quickly, coughing, or sneezing. It's thought to be due to the rapid stretching of the ligaments supporting the growing uterus. Usually harmless, but can be quite alarming.
Right.
And the other one, more related to the joint itself, is symphysis pubis dysfunction, SPD,
Ah, yes. Pain right at the front.
directly over the pubic symphysis. It's thought to be related to hormonal changes, causing ligamentous laxity, and some instability or widening at that joint. The pain is often described as pinching or aching, and it's characteristically worse with activities that involve separating the legs or putting weight through one leg at a time, things like walking, climbing stairs, getting in and out of a car.
So really important to ask about these specific triggers and associated symptoms.
Absolutely essential. Before we embark on months of musculoskeletal rehab, we have to be confident we've ruled out these other potential causes.
Okay, so we've covered the acute differentials and the importance of ruling out non-musculoskeletal causes. But now let's shift gears slightly towards the athlete with chronic groin pain. This is where it often gets really complex, doesn't it? We start talking about the groin pain syndrome, or GPS.
Yes, exactly. Chronic athletic groin pain is rarely about just one isolated structure failing. More often than not, you find multiple things going on simultaneously, or one problem leading to another. That's the essence of GPS.
And that's why a structured approach is so vital, because you could easily end up just chasing the symptom that hurts most today, missing the underlying driver.
Precisely. And that's where standardized frameworks become invaluable. The Doha Agreement classification is probably the most widely accepted and clinically useful one we have currently.
Developed by consensus among experts.
Yes, a group got together specifically to create a clinically based system. It helps us categorize the pain based on where it is and what specific clinical tests reproduce it. It brings clarity.
Okay, so let's break down those Doha categories. There are 4 main clinical entities, right, based on location and provocation.
Correct. 4 main types, defined purely by the clinical examination findings.
Adductor-related groin pain. Simple enough, the pain is felt primarily where the adductor muscles attach to the pubic bone. You'll find local tenderness on palpation there, and crucially, their pain is reproduced when you test their strength against resistance, trying to squeeze their legs together.
Okay, so confirms adductor muscle or tendon involvement.
Yes. Number 2, pubic-related groin pain. Here, the tenderness and pain are very specifically localized right over the pubic symphysis joint itself, or the bone immediately next to it. This points towards things like osteitis pubis inflammation or stress reaction in the bone, or symphyseal instability.
Right at the front midline.
Exactly.
Right.
Number 3, inguinal-related groin pain. The pain is located more in the inguinal canal region, just above the groin crease. The key here is tenderness along the canal, maybe over the deep ring. Andy, the pain gets worse with activities that increase intra-abdominal pressure.
Like the Valsalva maneuver we mentioned.
Yes, or resisted sit-ups, coughing, sneezing. That pattern strongly suggests involvement of the inguinal structures. Think sports hernia, posterior wall weakness.
Got it. And the 4th one.
Number 4, iliopsoas-related groin pain. This involves the main hip flexor muscle. You'll find tenderness when you palpate the iliopsoas muscle belly, usually higher up in the groin, often just lateral to the femoral artery. And the pain is reproduced either when the patient actively flexes their hip against resistance, or sometimes when you put the hip flexor on a stretch.
Okay, that framework seems really logical. Adductor, pubic, inguinal, iliopsoas, based on simple clinical tests.
It provides that essential starting point for organizing your thoughts and directing further investigation or treatment.
But here's where it gets really interesting and perhaps challenges some older assumptions. The epidemiology. Historically, a lot of the research, particularly on athletic groin pain, focused heavily on male footballers, didn't it?
Overwhelmingly so. And in that population, adductor-related groin pain was consistently reported as the most common entity.
Right. But recent evidence, looking specifically at female athletes, seems to paint a rather different picture.
It really does. And it's crucial that clinicians are aware of this. Studies looking at elite female athletes in team sports, football, hockey, basketball, and so on have found, firstly, that hip and groin problems are very common. One study reported a point prevalence of around 14.3% in a preseason screening setting, so it's certainly not just a male issue.
About 1 in 7 athletes.
Exactly. But the really striking finding was the type of groin pain diagnosed using those Doha criteria. In this large cohort of elite female athletes, the single most common clinical entity wasn't adductor-related pain.
It was
Iliopsoas-related groin pain. It accounted for almost 60%, 58.8% of all the clinical diagnoses made.
Wow, nearly 60%. That's a huge difference compared to the male football literature where adductors dominate.
A massive difference. In the same female cohort, adductor-related pain only accounted for about 12%, 11.8% of cases. Pubic-related was around 18%, and inguinal-related about 12%. So the iliopsoas was clearly the dominant finding.
That's fascinating. Why do you think that might be? Are female athletes just using their hip flexors more, or is there something else going on? Biomechanics? Anatomy?
It's likely a combination of factors. Anatomically, women tend to have a wider pelvis and potentially a larger Q angle, which can alter the forces acting across the hip and pelvis during movement. This might place different demands on the stabilizing muscles. Biomechanically, the demands of female team sports involving cutting, jumping, repeated acceleration and deceleration obviously load the hip flexors heavily. But perhaps there's also a factor of relative weakness or altered motor control. If the primary hip stabilizers, like the gluteals, aren't functioning optimally, the iliopsoas might become overworked trying to provide dynamic stability.
Compensation pattern.
Potentially, yes. And then there's the possible influence of hormonal factors. Hormones like relaxin can increase ligamentous laxity around the pelvis, potentially leading to slightly increased instability at the pubic symphysis or sacroiliac joints, which again might force muscles like the iliopsoas to work harder to compensate.
So it really challenges the idea that groin pain screening and prevention for female athletes should just mirror what's done for males, focusing mainly on adductors.
It absolutely does. If the most common issue is iliopsoas related, then maybe our screening should be focusing more on hip flexor strength, endurance, and control in female populations.
Which makes another finding from that same research even more relevant. They found that standard measures of hip adduction and abduction strength didn't actually correlate well with the athlete's self-reported hip function using the Hago score.
Yes, that was intriguing. It suggests that just measuring isolated peak strength of the adductors or abductors might not fully capture what's limiting the athlete functionally.
So testing how hard they can squeeze or push out doesn't necessarily tell you how well they can run, cut, or jump without pain.
Apparently not in this specific female cohort. It implies that other factors, maybe muscle endurance, motor control patterns, the timing of muscle activation, or indeed the presence of underlying structural issues like FAI or the iliopsoas pathology itself, might be more important determinants of their functional capacity and symptoms than simple peak strength in those specific muscle groups.
It really reinforces the need for a more holistic assessment, doesn't it? Looking beyond just isolated muscles.
Definitely. And it leads us nicely into thinking about how these different pathologies often linked together that vicious cycle you sometimes see in chronic GPS.
Or something like FAI might be the starting point.
Very often, yes. We need to understand this concept of the FA core instability cascade. Let's think it through biomechanically.
Okay.
FAI, especially the CAM type, fundamentally restricts the hip's normal range of motion, particularly internal rotation and flexion.
Right. The movements involved in impingement.
Exactly. So when an athlete tries to perform a powerful movement that requires that full range, maybe kicking a ball hard or sprinting with full hip extension and flexion, the bony block in the hip prevents normal joint movement.
So the body has to find that movement somewhere else.
Precisely. It compensates. And where does that compensatory stress often go? To the adjacent joints, the pubic symphysis and the sacroiliac joints. You get increased rotational or shearing forces across the pubic symphysis because the hips aren't moving freely.
Okay.
Repeatedly subjecting the pubic symphysis to these abnormal stresses can lead to microtrauma, inflammation, bone marrow edema, essentially osteitis pubis. That's your pubic-related groin pains potentially stemming from the hip restriction.
I see the link.
And at the same time, this altered movement pattern and stress can overload the tendons attaching around the pubis, particularly the adductor origin. So you develop a chronic adductor tendinopathy, your adductor-related pain, again, potentially driven by the underlying FAI.
So the FAI is causing secondary problems at the pubis and adductors.
Yes, and it doesn't stop there. This altered pelvic and hip mechanics can also disrupt the normal function and coordination of the core muscles. The abdominal wall might become functionally weaker or inhibited, especially the deeper stabilizers. This can then predispose the athlete to developing that posterior inguinal wall weakness, we talked about the sports hernia, or inguinal-related groin pain.
Wow. So FAI can potentially contribute to pubic, adductor, and inguinal-related pain.
It absolutely can. It highlights how interconnected this region is. The restricted hip sets off a chain reaction.
That really drives home the definition of groin pain syndrome. It's not just one thing. You mentioned a case study of a professional footballer that illustrated this perfectly.
Yes, a classic example that really cemented this concept for me. This player presented with chronic, debilitating groin pain that had failed multiple attempts at conservative treatment. When we investigated thoroughly, using the Doha framework and appropriate imaging, we found not one, but 4 distinct, established pathologies coexisting.
4. What were they?
He had severe bilateral osteitis pubis, evident on MRI with significant bone marrow edema. He had chronic bilateral adductor longus tendinopathy, again confirmed on imaging. He had a clinically obvious sports hernia on one side. And underlying all of this, he had significant bilateral cam-type FAI morphology.
Goodness, the full house.
Pretty much. And you could trace the likely cascade. The FAI was probably the silent underlying factor. Perhaps an acute adductor strain was the initial trigger that brought things to a head. That injury, combined with the restricted hip movement from the FAI, likely destabilized the pubic symphysis, leading to the severe osteitis pubis and making the adductor tendinopathy chronic.
Right.
And the ongoing instability and altered core mechanics then likely led to the development, or at least the unmasking, of the sports hernia.
So treating just one of those in isolation would have been doomed to fail.
Absolutely guaranteed to fail. If you only addressed his adductor tendinopathy, the underlying FAI, OP, and hernia would still be driving the problem. If you only fixed the hernia, the FAI and OP would persist. It required a comprehensive approach managing the bone inflammation, addressing the tendon pathology, repairing the hernia, and ultimately considering addressing the FAI, alongside intensive rehabilitation focusing on the entire kinetic chain. It perfectly illustrates why we call it a syndrome and why the systematic Doha evaluation is so critical.
Okay, we've really explored the musculoskeletal complexity, the FAI cascade, the concept of GPS, but there's another crucial category of groin pain we need to dedicate proper time to, one that's often missed or misdiagnosed, and frequently has a very different origin, neurological entrapment.
Yes, neuropathic groin pain is a significant and often very challenging clinical problem.
And one particular nerve seems to come up frequently, especially in the context of previous surgery. I'm thinking of ilioinguinal neuralgia.
Yeah.
That's certainly one of the most common culprits, particularly when we're talking about chronic pain after certain surgical procedures. It's a major focus in chronic post-surgical pain management.
So tell us about the ilioinguinal nerve. Where does it come from? What does it do?
Okay, so the ilioinguinal nerve typically arises from the T12 and L1 nerve roots in the lumbar plexus. It travels down, pierces through the abdominal muscles, the transversus abdominis and internal oblique, and then runs superficially in the inguinal canal alongside the spermatic cord in men, or the round ligament in women.
Right.
It has both motor and sensory functions. The motor supply is relatively minor, contributing to the internal oblique and transversus abdominis muscles, but its sensory distribution is extensive and clinically very relevant.
Where does it supply sensation?
It covers the skin over the upper inner part of the thigh, the lower part of the abdominal wall just above the pubis, and then the genital region, specifically the skin at the root of the penis and the upper part of the scrotum in men, or the mons pubis and labia majora in women.
Okay, quite a wide area, definitely overlapping with where patients report groin pain.
Exactly. And the key context, as you hinted, is that it's particularly vulnerable to injury or entrapment during surgery in that region.
What kind of surgery are we talking about?
The most common association by far is inguinal hernia repair. Whether it's an open repair or sometimes even laparoscopic, the nerve runs right through the operative field and can be easily damaged, stretched, cut, stitched into the repair, trapped by mesh, or even affected by scarring afterwards. It's estimated that chronic pain, often neuropathic in nature, develops in a significant minority of patients after hernia repair figures up to around 12% are often quoted, and ION is a major cause of that.
12% is quite high, considering how many hernia repairs are done.
It's a huge number of patients suffering from chronic pain. Other procedures can also put the nerve at risk, things like cesarean sections, especially with a Fannin-style incision, which cuts across the lower abdomen, appendectomies, or even abdominoplasty, tummy tuck surgery. Any incision or dissection in that lower abdominal inguinal area carries a potential risk.
And what's actually happening to the nerve to cause the chronic pain? Is it just cut?
Sometimes it might be completely severed, which usually results more in numbness anesthesia in its distribution, but more often chronic pain neuralgia results from partial injury, compression, or chronic irritation. So it could be trapped in scar tissue as things heal. It might be directly compressed or kinked by a suture that's been placed too tightly, especially if mesh is being fixed. The mesh itself can sometimes provoke a chronic inflammatory response, leading to fibrosis around the nerve, or there could be traction injury during the operation. This ongoing irritation or compression leads to the nerve becoming hyperexcitable and firing off abnormal pain signals. Ischemia, reduced blood flow to the nerve due to compression, can also play a part.
Resulting in that characteristic neuropathic pain quality.
Exactly. That's the first big clue clinically. Unlike the aching mechanical pain of most musculoskeletal problems, IIN pain is typically described as burning, stabbing, shooting, electric shock-like, or tingling. And it follows that specific sensory distribution we talked about, lower abdomen, inner thigh, genitals.
Right. Are there other clinical clues, maybe on examination?
Yes. Patients might have altered sensation, either hypersensitivity, allodynia where light touch is painful, or reduced sensation, hypoesthesia, in the area supplied by the nerve. Sometimes you can elicit the pain by tapping gently over the nerve's course near the anterior superior iliac spine, ASIS, or the pubic tubercle, a positive Tenel sign. And another really important observation is their posture and gait. Patients with significant IIN often walk hunched over, keeping their hips slightly flexed.
Why is that?
Because extending the hip fully stretches the anterior abdominal wall and the structures in the inguinal region, including the trapped or irritated nerve. That movement provokes their pain, so they subconsciously avoid it by maintaining a slightly flexed posture.
That's a really useful clinical sign to look out for. But even with all that, how do you definitively confirm the diagnosis, especially if the pain distribution overlaps with, say, hip pathology?
That's where diagnostic nerve blocks come in. They are absolutely crucial. The gold standard for confirming IIN is demonstrating significant, even if temporary, pain relief after a precisely targeted local anesthetic injection around the ilioinguinal nerve.
So you numb the nerve, and if the pain goes away, that strongly suggests the nerve is the source.
Exactly. We typically do this under ultrasound guidance now to ensure accurate placement of the anesthetic right where the nerve lies, usually between the internal oblique and transversus abdominis muscles. If the patient gets, say, 80% or more relief from their typical pain while the block is working, that's considered a positive diagnostic block.
And if the block doesn't work?
Then you have to seriously reconsider the diagnosis. Maybe the block wasn't technically accurate, or perhaps the pain is coming from a different nerve, like the genitofemoral or obturator nerve, which also supply sensation around the groin. Or it could be that the pain isn't primarily neuropathic at all, and you need to go back and look harder for a musculoskeletal cause, like severe OA, FAI, or perhaps referred pain from the spine. The block is a critical decision-making tool.
Okay, let's say the block is positive, confirming IIM. What's the treatment approach? I assume you start conservatively.
Always. Standard pain management approaches first. Simple analgesics, NSAIDs. But because it's neuropathic pain, we often quickly move to medications specifically targeting nerve pain.
Like gabapentinoids.
Yes, drugs like gabapentin or pregabalin are often first-line options. Sometimes tricyclic antidepressants like amitriptyline can be helpful too, used in low doses for their pain-modulating effects. Alongside medication, physiotherapy focusing on gentle mobility, desensitization techniques, and avoiding provocative postures is important.
Right. But what if those conservative measures, even over several months, just aren't providing enough relief? The pain remains intractable. What are the next steps?
Then we move up the treatment ladder towards more interventional options. The first step here is often repeating those ultrasound-guided nerve blocks, but this time adding a corticosteroid to the local anesthetic.
To reduce inflammation around the nerve.
Exactly. The idea is to provide not just temporary diagnostic relief, but potentially longer-lasting therapeutic relief by calming down the inflammation and irritation. Ultrasound guidance is key here for accuracy and safety.
How long does relief from steroid injections typically last?
It's variable. Some patients get weeks or even months of significant benefit. Others find the relief is quite short-lived. If the blocks provide good but transient relief, that's when we start considering more advanced, potentially ablative techniques.
Ablative meaning you're trying to interrupt the nerve signal more permanently.
Essentially, yes, but often aiming for a prolonged temporary interruption rather than permanent destruction initially. The two main techniques used here are microwave radiofrequency nerve ablation, RFA, sometimes just kind of radiofrequency lesioning, or cryotherapy, cryoablation.
How do they work?
With RFA, a special probe is guided, again usually with ultrasound, to lie precisely alongside the ilioinguinal nerve. Radiofrequency energy is then delivered through the probe tip, generating heat which creates a controlled lesion on the nerve. This selectively damages the small pain-transmitting fibers, A delta and C fibers, while trying to spare the larger motor and sensory fibers, although some sensory change is common. Cryotherapy uses a similar probe, but instead of heat, it uses extreme cold, often generated by pressurized gas like nitrous oxide or carbon dioxide, to freeze the nerve. This causes ice crystals to form within the nerve axon, disrupting its structure and function, again leading to a block in pain signal transmission.
And what's the advantage of these over just going straight to surgery to cut the nerve?
The main advantage is that they are minimally invasive, usually performed as outpatient procedures. And crucially, the nerve block they produce, while intended to be long-lasting, is often not permanent. The nerve can potentially regenerate over time, so they offer prolonged pain relief, typically in the order of 6 to 12 months, sometimes longer, without the definite permanent numbness that comes with surgical nerve cutting.
I see. So it gives the patient a significant pain-free window.
Exactly. A window to engage fully in rehabilitation, break the chronic pain cycle, maybe reduce reliance on medications, and the procedures can often be repeated if the pain eventually returns as the nerve recovers. They bridge the gap before considering irreversible surgery.
Which brings us to that final option, surgical neurectomy, cutting the nerve. When is that genuinely indicated?
It really is reserved as the treatment of last resort. It's for patients with clearly diagnosed intractable INN who have failed to get sustained relief from all other reasonable options medications, repeated blocks, RFA, or cryoablation over a prolonged period, usually many months or even years.
And the procedure involves?
It involves surgically exploring the inguinal region, carefully identifying the ilioinguinal nerve, tracing it back to a point proximal to or upstream from the suspected site of injury or entrapment, and then deliberately excising a segment of the nerve. The aim is to remove the damaged section and prevent painful signals from reaching the spinal cord.
Success rates?
Generally reported as quite good for pain relief, often in the range of 70% or higher in appropriately selected patients. But the significant, unavoidable trade-off is permanent numbness, or at least altered sensation, hyposthesia, in the entire area supplied by that nerve. Patients have to be fully counseled about that beforehand.
That makes sense. It's a definitive but sacrificing procedure. You mentioned something interesting earlier about prevention, though, prophylactic neurectomy during hernia repair.
Yes, there's actually quite compelling evidence now, including from systematic reviews and meta-analyses, suggesting that performing a prophylactic ilioinguinal neurectomy, deliberately cutting the nerve at the time of the initial open inguinal hernia repair, significantly reduces the risk of developing chronic post-operative groin pain or neuralgia afterwards.
Really? So sacrificing the nerve routinely prevents more pain later?
The data suggests it does, likely because it avoids the risk of the nerve getting accidentally injured, trapped, or caught in scar tissue during the repair and healing process. It's a bit controversial, as it means intentionally causing numbness in all patients to prevent chronic pain in a subset. But it highlights just how significant and difficult to treat chronic post-hernia pain can be, that prevention is being seriously considered and researched.
Right. We've journeyed through the musculoskeletal complexity, the FAI cascade, GPS in athletes, and the specific challenge of neuropathic pain like IIN. Let's try and bring this all together now into a practical, systematic management framework. Starting with diagnostics, what's the essential imaging toolkit?
A systematic approach to imaging is fundamental. You can't manage what you haven't accurately defined. We rely on a combination, typically. Number 1, X-rays. Need standard AP pelvis views for basic bone structure, looking for obvious OA or signs of dysplasia, but critically, we often need dynamic views as well. The flamingo view is particularly useful.
Flamingo view. Standing on one leg.
Exactly. An X-ray taken while the patient stands on one leg, then the other. It puts stress across the pubic symphysis, and you look for any vertical shift or instability which can indicate symphyseal dysfunction, something easily missed on a standard two-legged stance X-ray.
Clever. Okay, X-rays first. Then,
Number 2, high-quality MRI. This is really the workhorse for looking at both bone and soft tissues in detail. It's excellent for detecting bone marrow edema, the hallmark of osteitis pubis or a stress reaction. It assesses tendon health, looking for tendinopathy or tears in the adductors or rectus abdominis. It can visualize labral tears in the hip. And as we discussed, it's essential for assessing and measuring the hip morphology for FAI.
got it. And the third component?
Number 3, dynamic ultrasound, US. Ultrasound offers a real-time functional assessment, which can be incredibly valuable, particularly when you suspect inguinal-related pain or a sports hernia. You can watch the abdominal wall move as the patient strains or coughs, looking for subtle bulging or weakness that might not be apparent statically. You can also assess tendons dynamically.
So X-ray for bones instability, MRI for detailed soft tissue and FAI morphology, and dynamic US for functional assessment, especially of the abdominal wall.
That's a good summary of the core imaging protocol.
You mentioned the FAI metrics again, the alpha angle and head-neck offset. Can we just revisit why those specific numbers, like alpha angle over 55 degrees or offset under 10 millimeter, are so clinically relevant? They're not just arbitrary cutoffs.
No, not arbitrary at all. They represent thresholds derived from studies correlating bony shape with the likelihood of intra-articular damage and symptoms. The alpha angle, remember, measures how far the femoral head-neck junction deviates from being perfectly spherical. Once that angle gets above about 35 or 60 degrees on the appropriate views, it signifies a bump that is mechanically large enough to reliably cause impingement against the acetabular rim during hip flexion and rotation.
So it quantifies the mechanical risk.
Precisely. It moves the diagnosis from a subjective clinical suspicion based on the FEIR test to an objective, measurable structural abnormality. A significantly elevated alpha angle provides strong evidence that the patient's symptoms may be directly related to this bony morphology, and therefore they might benefit from surgery and osteoplasty to correct it.
Okay, and the head-neck offset, less than 10 millimeter.
Similarly, the offset measures the concavity, or lack thereof, at the femoral neck junction. A normal hip has a good concave waist, allowing clearance during movement. When that offset is reduced less than 10 millimeters, sometimes even less than 8 millimeter, depending on the study, it indicates a flatter, more pistol grip-like shape. This again significantly reduces the clearance between the femur and acetabulum during flexion, increasing the risk of impingement, labral damage, and subsequent OA.
So these numbers directly inform prognosis and treatment decisions.
Absolutely. They help us decide, is this a patient with a clear structural driver for their pain who might be a good candidate for arthroscopic surgery? Or is the morphology borderline, suggesting we should pursue non-operative management more aggressively first? They are critical data points.
Right, that clarifies their importance. Now, once we have the diagnosis pinned down, whether it's FAI, GPS, or even post-nephrectomy rehab, the cornerstone of management, operative or non-operative, seems to be physical therapy and rehabilitation.
Without a doubt, surgery might fix a structural problem, but only high-quality rehabilitation can restore optimal function and address the underlying biomechanical issues and compensations that often accompany chronic groin pain.
And you mentioned there are core pillars that effective rehab programs should address. 4 key areas.
Yes, based on current evidence and understanding of lumbopelvic mechanics, a comprehensive program for FAI, GPS, or related conditions typically needs to incorporate these 4 pillars. Pillar 1 is postural control. This is fundamental. Many patients with chronic groin pain develop compensatory postures, often involving an excessive anterior pelvic tilt.
Where the pelvis tips forward.
Exactly. This position shortens the hip flexors, increases lumbar lordosis, and can alter the stresses across the pubic symphysis and hip joints. So the first step is often teaching the patient awareness and control how to find and maintain a more neutral pelvic alignment. This starts simply, maybe with supine pelvic tilts, learning to gently flatten the lower back by engaging the lower abdominals and pelvic floor. Then progressing to maintaining that neutral pelvis during more complex movements, sitting, standing, squatting, etc. It's about re-educating their default position.
Okay, postural control first, pillar 2.
Pillar 2 is core stabilization. And here, we're specifically talking about the deep core muscles, the transversus abdominis, the multifidus in the lower back, the diaphragm, and the pelvic floor muscles. These form a stabilizing corset.
Right, not just the six-pack muscles.
No, exactly. If these deep stabilizers are weak or inhibited, the body compensates by overusing the bigger superficial muscles like the rectus abdominis or the obliques. This can actually increase shearing forces at the pubic symphysis and doesn't provide true segmental stability.
So the exercises need to target these deep muscles specifically.
Yes, the progression needs to be careful. Starting with low-load exercises where the focus is purely on engaging the deep core before moving the limbs. Think exercises like bent knee fallouts, heel slides, or modified dead bug variations, all done with meticulous attention to maintaining that neutral spine-pelvis position. Then you progress the challenge, maybe adding load, longer levers, straightening legs, arms, or moving to positions like quadruped, bird dog, or planks. But the quality of control is paramount. We often use benchmarks like being able to hold a neutral spine-prone plank for, say, 60 seconds as a measure of core endurance and control.
Okay, core stability is pillar 2. What's pillar 3? Especially thinking about that data on female athletes and iliopsoas issues.
Pillar 3 is hip strength and motor control. This is absolutely crucial. We need to address any weaknesses around the hip, but also, perhaps more importantly, abnormal movement patterns or muscle imbalances.
Like the gluteal weakness you mentioned.
Yes, weakness of the hip abductors, gluteus medius and minimus, is incredibly common in patients with groin pain, FAI, and related issues. When these are weak, patients often compensate by over-recruiting other muscles, like the tensor fasciae latae, TFL.
Which is also an internal rotator of the hip.
Exactly. So TFL dominance can actually drive the hip into more internal rotation, potentially worsening impingement in FAI. So rehab needs to specifically target activating and strengthening the gluteals while minimizing TFL compensation.
How do you achieve that?
Progression is key, starting with simple, non-weight-bearing exercises like sideline clam shells or hip abduction, focusing on pure glute activation, then moving to weight-bearing exercises. For example, when using resistance bands for exercises like sidestepping or monster walks, a really important technique is to place the band lower down around the ankles or even the forefeet rather than just below the knees.
Why does that make a difference?
Placing the band lower significantly increases the external rotation torque that the hip abductors, glutes, have to resist. It demands much more work from gluteus medius and minimus to keep the knees tracking correctly over the feet and prevents the TFL from easily taking over. It's a simple change, but forces better quality recruitment.
That's a great clinical tip.
Then you progress further to more functional unilateral exercises, things like step-ups, step-downs, single-leg squats, lunges in multiple planes, always focusing on maintaining that pelvic control and proper hip muscle activation. And, of course, addressing hip flexor strength and control if iliopsoas issues are suspected or confirmed.
Makes sense. And the final pillar, pillar 4.
Pillar 4 is flexibility and mobility. But with the caveat, this must always be done within a pain-free range. We're not trying to force joints into painful positions.
Right.
This pillar includes several components. Static stretching for muscles identified as tight, maybe the adductors, hip flexors, rectus femoris, iliopsoas, hamstrings, or hip external rotators. Stretches are typically held for 15-30 seconds. Myofascial release techniques using tools like foam rollers or lacrosse balls can be helpful for addressing trigger points or fascial restrictions, particularly around the glutes, TFL, or piriformis. And dynamic mobility drills are also important, especially as the patient progresses. Things like leg swings, pendulum swings, hip circles, or open the gate, close the gate rotational movements. These help improve functional range of motion in a controlled way, preparing the tissues for activity while reinforcing the postural control learned earlier.
So postural control, core stability, hip strength motor control, and flexibility mobility. Those 4 pillars form the foundation.
They do. A comprehensive, progressive program addressing all 4 gives the patient the best chance of restoring normal function and reducing the risk of recurrence.
Now, the difficult question. When does this dedicated rehab pathway potentially need to be augmented or replaced by surgery? What are the decision points?
It's always a combination of factors, but symptom duration and response to conservative care are key. Generally, if a patient has had significant functionally limiting groin pain for a prolonged period, say 12 to 24 months, despite trying various treatments, surgery becomes a more serious consideration. Or, perhaps more relevantly, if a patient undergoes a well-structured, intensive rehabilitation program like the one we've just outlined, for a dedicated period, typically 3 to 6 months, and fails to make meaningful, objective improvements in their pain and function, then that's often the point where surgical referral is appropriate.
So, failure of a good trial of conservative care.
Exactly.
Right.
Not just dabbling with a few exercises. A proper, supervised, progressive program. If that fails, then for FAI, the discussion turns to hip arthroscopy for osteoplasty and labral repair debridement. For chronic recalcitrant adductor tendinopathy, maybe an adductor tenotomy or release. For sports hernia, surgical repair.
And post-surgery, the rehab starts again, but tailored.
Absolutely. Postoperative rehabilitation is just as crucial, if not more so. But the initial phases will be dictated by the specific surgery performed and the need to protect healing tissues. For instance, after a labral repair in the hip, there will likely be restrictions on weight bearing and range of motion for several weeks to allow the repair to consolidate. Then you gradually progress back through those same 4 pillars, regaining mobility, rebuilding core control, restoring hip strength, and eventually returning to full function. Surgery is just one step in the overall management process. #tag outro.
Well, this has been an incredibly thorough exploration. I think what stands out most is the need for that real shift in mindset when dealing with complex groin pain, moving away from thinking about just one structure in isolation towards a much more integrated assessment, really evaluating the whole lumbopelvic kinetic chain, objectively looking at hip morphology with those metrics we discussed, and being rigorous about ruling out the non-musculoskeletal and neurological causes.
That meticulous, systematic approach is everything. Effective management of chronic groin pain isn't about guesswork. It relies on using validated frameworks like Doha, investing in comprehensive imaging to understand the specific structural issues, and then committing both the clinician and the patient to intensive, structured rehabilitation that addresses the underlying biomechanics across all those pillars. Knowledge and structure are paramount.
If you found this deep dive valuable for your clinical practice, please do consider taking a moment to rate and share our discussion with colleagues.
Sharing knowledge is always beneficial.
And that brings us to our final provocative thought for you to mull over. We spent some time discussing that really striking data showing iliopsoas-related pathology is the dominant finding in elite female team athletes, unlike in males where adductors often prevail. So the question is, should this fundamentally change our approach to injury prevention screening in women's sports?
A critical question.
Should we now be routinely incorporating specific hip flexion strength assessments, maybe iliopsoas endurance tests, and targeted iliopsoas injury prevention exercises into screening protocols for female athletes, with the same emphasis that's historically been placed on adductor screening in male footballers?
It certainly warrants serious consideration if we aim for evidence-based and equitable sports medicine practice.
Food for thought indeed. Professor Mo Imam, thank you so much for sharing your expertise and guiding us through such a complex area with such clarity.
It's been a real pleasure. Thank you.
Join us next time for another Deep Dive Ortho.